Yes, isn't that funny? I didn't even think about it because I was thinking, when's the first time I ever came to force? And it was a long time ago.
Yeah, that was when Sue sat down and said we need an organization.
Yeah.
So she received her medical degree from Northwestern University. Hi, come on in. Come on up front.
Yeah. Come up front.
It's a very small informal group.
Well, we're going to try to make it warmer up here too, just by being around each other with our body heat.
So your medical degree is from Northwestern University and a master's degree from the Harvard School of Public Health. She completed an obstetrics and gynecologic oncology at the Johns Hopkins Hospital and a gynecologic oncology fellowship at MD Anderson Cancer Center. She completed her doctoral degree in public health on cost analysis at the University of Texas School of Public Health and an associate fellowship in integrative medicine at the University of Arizona.
Hey.
So quite the range, but we welcome you. Thank you for being here.
Good to be here. Good to be here.
To hear what you have to say.
Yeah.
Session.
Let's talk first, and then we'll questions. We should have plenty of time. So I said what's new, but also old and relevant, only because obviously there's a lot of things we've been doing for a long time that are still relevant to the care of endometrial cancer. So we're going to talk about endometrial cancer in general, talk specifically about mostly people with Lynch syndrome. That's what puts people at risk for getting endometrial cancer, the main risk factor that we've identified. We'll talk about prevention, and I was looking at my slides and I was thinking prevention/early detection, right? Picking up the cancers early, which is a possibility in endometrial cancer as it is in breast, different than, say, ovarian cancer, where we don't really have tools for that early detection part of things. And then treatment. I always use abbreviations and just have learned to define them ahead of time. So endometrial cancer, ENCA, OVCA, QOL, quality of life, overall survival, so time from cancer to how long you live with/without it. Progression-free survival, that time between treatment and if recurrence occurs, recurrence. Mismatch repair deficiencies, we're going to talk a lot about these. That is the actual genetic change that is connected with Lynch, and we'll talk more about it, but I'm only going to use MMRD, but in the literature you'll see all of these things, dMMR, D, big MMR. MSI actually stands for microsatellite instability, but it essentially means the same thing as we're looking at it when we do tumor testing. So inherited or germline mutations, those are the ones that we're born with. Sporadic or somatic mutations, we know, right, that cancers are all mutations that happen over time and accumulate. Even people with inherited predispositions have just one mutation, and it takes two to actually get a cancer. So sporadic or somatic mutations are the ones that happen in the tumor themselves. And in this way, what we understand about like inherited cancers has taught us a lot about sporadic cancers. And then I am going to talk about body mass index, BMI. It is not a perfect health, measure by any means, but it's kind of useful in some of the ways we think about certainly hormonally dependent cancers. All right, so uterine cancers, you can get cancer here. Oh, my little arrow doesn't work over there. Maybe this, do I have a pointer? Oh, I do. So, right, you can get cancer in the muscle wall. Those are sarcomas. Today we're talking about the cancers that happen here on the lining, the endometrium. And it kind of makes sense. The endometrium is the most active part. Similar if you think about it to breast tissue, right? Tissue that changes with every single month, every single cycle, hormonal changes leading to those opportunities, right? Lots of cell division leading to opportunities for mutations to happen. And about 3% of women in the United States get endometrial cancer. It's the fourth most common cancer in women, with the most cancers occurring somewhere between the ages of 60 and 70, smaller percentage occurring before 40, and a big percentage of that before 40 we think are related to inherited predispositions. We are seeing increasing rates of endometrial cancer, both regular endometrial cancer, but also some of the aggressive types. And especially among African American women, we're seeing increasing rates of endometrial cancer. We don't totally understand why. We have some thoughts, and we'll discuss those. So we'll talk about risk factors mostly because they present us like opportunities for prevention. So endometrial cancer is about this imbalance between estrogen and progesterone, right? So when someone is cycling, most of the month the ovary is making estrogen. Estrogen's causing that lining of the uterus to build up, build up, build up, grow, it's stimulated. Then somebody ovulates. Ovulation tells the ovary to stop making estrogen, start making progesterone. And in the uterus, progesterone is an inhibitory, a turn-off hormone, causes the lining to shed, voila, period. Of course, different in the breast. In the breast, progesterone is stimulating, right? And so hormones are tricky because they don't do the same things all over the body, same as some of the hormone relatives that we use for treatment, things like tamoxifen, right? An anti-estrogen in the breast, a pro-estrogen in the uterus. So risk factors. So the reason being overweight or obese increases endometrial cancer risk is kind of multifold, we think. One level of it is plain old estrogen. Our body will take our fat tissue and it will convert it into a very weak form of estrogen. So we just have extra, it's called estrone. It's not an extremely active, but it's active enough to mess with things. And it's active enough, we think, to mess with ovulation. And so ovulation gets suppressed. And so then people who are overweight will have less often ovulation. So then again, they're getting that lack of balance between estrogen and progesterone. We also think some of the diseases connected to being overweight and obese, like diabetes, itself in some way contributes to endometrial cancer because of insulin growth factor and other kind of stimulating hormones that come with that. History of irregular menstrual cycles, polycystic ovarian syndrome. I mentioned tamoxifen, but as I said, that's why it's a pro-estrogen in the uterus. Unopposed estrogen, of course, and this is actually how we made the big old connection. It was during this time when we were like, oh, estrogen, it's like the new youth serum, and we were like throwing estrogen around like it was water. Next thing you know, we had increased risks of endometrial cancer, and then we started doing the other, and of course the pendulum swung to the nuts, where then we were like, oh, estrogen's evil, and anyway, somewhere in between, good and bad, like lots of things in life. I mentioned the diabetes, and then of course we're spending a lot of time talking about genetic stuff. That's why it's at the bottom of the list. Oops, sorry. All right, so opportunities for prevention. That's that issue of protective factors. So pretty much anything that gives progesterone exposure to the uterus decreases the risk of endometrial cancer. And interestingly enough, the ovary also. Right? So oral contraceptives decrease the risk of endometrial cancer and ovarian cancer by 30 to 50%, really for relatively short use, right? 1 year of use will decrease a lifetime potential for getting endometrial or ovarian cancer by 10%. Pretty remarkable. Progesterone IUDs are probably our most effective way at getting progesterone right to the place we want it. And is actually used for treatment. We'll talk about that. Having been pregnant, what? How does that work? We used to think it was just because it changed how many ovulations, but pregnancy is a high progesterone state, right? Like the levels of progesterone we have during pregnancy are multiples higher than we have in the non-pregnant space, and we think that protection, again, is really a lot more than the lifetime, right? One pregnancy probably decreases the risk the same, between 10 and 25%. For both, again, ovary and endometrial, actually. Having a normal body mass index or somewhere between 20 and 25. Again, noting that normal, who knows where that range is, but it's about like the extra estrogen and the impact on ovulation. An active lifestyle, regardless of body mass index. So that's somewhere that 30 to 60 minutes, 5 times a week. Lots of data, especially around the 30-minute number, 5 times a week, being protective for all kinds of cancers, breast, colon, prostate, but also endometrial. It's harder for us to get data around ovarian cancer, but I'm kind of talking about it because if Lynch syndrome interest is what brought you to the room, obviously ovary is a part of that too. And then the Mediterranean diet, actually, of some of the cancer types that have been actually connected to being prevented by a Mediterranean diet. Endometrial is one of them, as is breast and colon cancer and prostate cancer. So we used to, and we still do in some ways, think about endometrial cancer based on what it looks like under the microscope. And we used to basically think of like two types, right? The one that is all about being stimulated by estrogen and protected by progesterone. This one is more amenable to being cured. And usually there's a precancerous phase, so that concept of early detection where we can actually pick it up when it's still in its precancerous phase is part of it. There's different names for it: complex atypical hyperplasia, the old name, endometrial intraepithelial neoplasia, the new name. And then there were these type 2 ones, the ones that we're seeing the increasing incidence of, especially in African American women, these more aggressive ones that metastasize earlier, have some behaviors in common with endometrial cancer. But now we've kind of changed that. And it's in a really good way, where we're learning that there's genetic and molecular markers that can really help us understand different cancers. And really, again, it was the genetic changes of Lynch syndrome that started us along this path to understanding that these genetic changes actually tell us about how the cancer is going to act, and then what kind of treatments the cancer is going to respond to. And then, of course, like these same changes that are part of like an inherited process of Lynch happen in the tumor itself, and these mismatch repair changes that I mentioned, they are the most common change that we see in endometrial cancers. And then we'll talk about immune checkpoint inhibitors. Those are those treatments that are especially thing. So this is the nice, really easy to read table from the NCCN on the different tumor types. But I did, and it was funny, Juanita was like, you put the same slide in twice. I'm like, yes, I made it bigger for myself and everyone else. So right here in the middle, these MSI ones, these are sort of characterizing those Lynch-related tumors, where we're learning like those are the ones that are really susceptible to radiation. And of course, those are the ones that these immune therapies, the checkpoint inhibitors, immune checkpoint inhibitors, have shown incredible response to. And now in retrospect, we're learning that they're actually quite active for many endometrial cancers. And just in 2023, we started introducing the use of these therapies into first-line treatment for advanced endometrial cancers. And then, of course, there is a category we haven't learned a lot about. I think, I know it's still on there, the ultra-mutated. We haven't learned enough, but we're there. All right, so what makes hereditary endometrial cancers different? You know, there's that main difference, which is that people start out with that one genetic, mistake already. And so they're predisposed to others. But like all of the cancers that are part of an inherited predisposition, all that environmental stuff matters, right? The same things that increase risk come into play, the same things that protection, that are part of protection, come into play. And so all of that stuff is still relevant, both the, trying to avoid risk factors and trying to harness the power of those protective factors. You're right, not that I recommend go get pregnant so you don't get endometrial cancer, but bonus side effect. I put a little tiny word about Cowden syndrome in here because there was a time we thought it might be connected. We're not sure, if that's a concern for someone in the room, come talk, we'll talk. But I'm taking a bunch of data from the National Comprehensive Cancer Network. They are a great source of information, very reliable, very middle of the road, or cautious in a way, but still good data. So lifetime risk of getting endometrial cancer, if you have this MLH1 gene change, is between 34 and 54%, with the average age about 15 years younger, 10 to 15 years younger than if you weren't born with that genetic change. MSH2 and EPCAM, 21 to 57%. Again, right, we don't totally understand them, and the changes are sometimes different. And in a way, like learning about the somatic mutations, hopefully will also feed back and teach us more about Lynch. MSH6, about probably the highest risk. Some think it's, almost 50%. And, it's very interesting. We used to call Lynch syndrome HNPCC, hereditary non-polyposis colon cancer, but for some people, their risk of endometrial cancer was higher than their risk of colon, and so we thought like that was like a problem. Now, I also have a problem with naming shit after people because I don't find that to be helpful either. On the other hand, like, would I rather have something that puts people down the wrong street versus no street? I'd rather go on no street. So anyway, Lynch syndrome, it is. People talk about if we should call it, mismatch repair deficiency syndromes or something like that, and maybe, we'll see. I honestly think like that's one of those places where like the advocacy community could help us, right? Because people who have these changes are going to be in some ways the most thoughtful about how to talk about them. And then I talked about the average age of presentation, and it's not a universal. Something we learned in the BRCA mutation ideas that like getting cancer early is not the universal. And that's why when we used to use age at diagnosis as kind of the thing that led us to genetic testing or led us to recommend people have evaluation or have their family evaluated, like probably that's how we were missing people. And that's why like this thing, every single endometrial cancer is automatically tested for mismatch repair deficiencies. The tumor itself, and then if they're found there, then we work our way back to the idea of, is this something unique just to the tumor, or is this something that could have been inherited? And so push people on to genetic testing based on that. I don't think there's anything else there. Real quick, the ovarian cancers. So about 2% of ovarian cancers are related to Lynch. The ovarian cancers are a little bit different than usual ovarian cancer, which is high grade or serous. These types are more those related to endometriosis or that look more like the lining of the uterus. So we're thinking that that whole process, the mismatch repair process, is a more important thing, right? Any cell that's growing and dividing, there's a tendency to mistake, and then there's genes that are built into the system to fix those mistakes. And so we think that's kind of how cancers walk a path. So the kind of mistake, this mismatch repair mistake, maybe is more about like also endometriosis, also this more aggressive clear cell kind of cancer. The range, 3 to 20%, we're not sure. These are the NCCN risks that, again, they're like accumulated over time. The more data we get, the more narrow these ranges ideally will get, where the highest risk may be this MSH2. And it's possible that just plain old PMS2 mutations are not connected to an increased risk of ovarian cancer. It's tricky though, because it is reported, and so then we start wondering, like, is it something about the actual, like we say mutation generically, but there are different changes that happen in the gene, and so maybe it's about the exact change and what it contributes to. Are there connections to fallopian tube and primary peritoneal cancer the way there are in BRCA? Maybe, although those are a serous type of cancer, because that's the fallopian tube and the lining of the fallopian tube. Those are the kinds of cells that live there naturally. So we're not sure, but there's sort of no reason to ever leave fallopian tubes in someone if you're taking out their ovaries and their uterus. So it becomes kind of a non-issue. And of course, I talk about the ovary cancer because as we move on to talking about what kind of care we recommend, if someone's at risk for ovarian cancer, we might not focus on the early detection of the lining of the uterus cancer when they might get a cancer that's more deadly, that we don't have a test for early detection. So just a slide on this idea of like, does having a BRCA mutation increase your risk of endometrial cancer, specifically those serous, the type 2, the more aggressive ones? Possibly. possibly BRCA1, like the data's really unclear, it's hard to suss it out. You know, as we started learning about the complexity of hormone replacement therapy in people who had risk-reducing surgeries, we've done more and more hysterectomies at the time of risk-reducing surgery, so that's decreasing even the, in quote, chance to find out about this. Do we really want the chance to find out somebody has endometrial cancer? No, it's kind of nice to protect it. But I think as we continue to follow people longer and longer, and people are having their BRCA mutations identified at younger and younger ages, theoretically we're going to understand this more. And, you know, I have been coming to force for a very long time, as we were discussing earlier. And I have to say, right, like early on, we were just so darn dogmatic, you know. This is what you need. You need your ovaries removed, blah, blah, blah. You don't need a hysterectomy, blah, blah, blah. And it really was the interaction of like, you know, I really struggled with like the bleeding when someone was trying to put me on estrogen replacement, and I wish someone had mentioned I could have just had my uterus removed at the same time. You know, those kinds of conversations. I think now we have to introduce this fact into those conversations too, like, is there potentially a risk-reducing role, even if it hasn't been solidly proven yet, right? In the beginning, we didn't think fallopian tubes were important in ovarian cancer. Lo and behold, they may be more important than the ovaries in that whole disease process. All right, so when we do compare, you know, non-mutation carriers to mutation carriers, what are the differences? We already talked about the age issue and why that might be. But this is kind of a challenge, right? This lower body mass index, kind of meaning that even if estrogen is increasing risk and progesterone is protective, it's not as effective, right? That we're much more likely to see people with normal body mass indexes who have endometrial cancer and learn that they're mutation carriers, where it's possible that the gene itself is enough, and that it's not just about a gene change plus where you can manage to protect enough. Is progesterone protective enough to completely prevent? Possibly not. More likely to be those endometrioids, same as the ovaries, a certain kind. More likely to have cancers that grow down here into the lower uterine segment, which is just like a predictor of a higher chance of coming back. We use that to sometimes guide adding radiation therapy. But again, telling us that maybe these cancers are a little bit different, and we haven't quite figured that part out of why. More to learn. All right, I'm going to do a bunch of slides now with quotations all over the place because I took them straight out of the NCCN because I feel like it's valuable to use their language, and then I'll tell you why I put them in quotes and I don't strictly use them. So they talk about like prompt reporting and evaluation of any abnormal bleeding, should have an endometrial biopsy. Hysterectomy has been shown to decrease the chance of dying of endometrial cancer, right? But it can decrease the chance of getting endometrial cancer. So what? This is the deal. Endometrial cancer, fortunately, because there's symptoms and because it tends to be a slow process that's confined to the uterus early on, because there is a precancerous phase that has symptoms associated with it, we are very good at curing endometrial cancer. And I think this is like one of those challenges that comes up in breast cancer too, when you're thinking about, do I really want to have a major operation and have body parts removed for the sake of something that's preventable, when maybe it doesn't actually change my chances of dying of the cancer, right? If the cancer is curable, maybe I kind of wait and get into that space. And again, like that's a really personal decision, right? There's plenty of people I've taken care of who are like, I never want the CA word to be connected to me. I don't want to be one of those people who gets that weird one that's in the lower uterine segment, it sneaks out to a lymph node early, and suddenly I'm getting whole pelvic radiation when you were telling me like this could be detected early. And I think that's why these NCCN guidelines are like, they're not always helpful like in real life, but that's why they're worded that way. So timing of total hysterectomy can be individualized, blah, blah, blah. Obviously, we think about, are people done with their childbearing? what's their family history, what's the actual mutation they have and the risks associated with that, and then what are their risks of ovarian cancer, so how are we going to bring that in? And again, they do all this hedging around, like, should people be getting endometrial biopsies? And what I say is, ultrasounds are not helpful if you're still having periods, right? Because ultrasounds are just looking at the thickness of the lining of the uterus. It's supposed to get thick every month. And we know people who have fibroids, in African American women, ultrasounds are just not as effective even after menopause. And so, you know, there's all these where tissue is the issue, right? Getting an actual biopsy, telling you what's actually there. I think there's some value to it. Is it uncomfortable? It sure darn is, right? Do we generally do it in the office to try to avoid general anesthesia, et cetera? Yes. So it can be a pretty uncomfortable thing, but that's one of those one-on-one conversations to have with someone about, is it worth it for me to go through that, and how often do I do that, and how is it really benefiting me? The transvaginal ultrasound thing that ends up coming into play, though, is for people at risk for ovarian cancer, could it potentially help us? The real answer to that is no, but there are some studies that suggest we pick up some cancers slightly earlier, right? Instead of stage 3, we're at stage 2. And these endometrioid cancers, the ones that are more connected to Lynch, they tend to stay confined to the ovary longer and less often involve the fallopian tube, so maybe. Right? So I'm not saying ultrasound doesn't have a role, it just doesn't have the same, like, if it's normal, you know, we're scot-free, or if it's abnormal, it means there's something horrible going on. Both things are, there's false negatives and false positives. So that's that. Did we ever get to what I believe? Oh yeah, here we are with I believe. So I think it's reasonable, and I'll have these individual conversations with people. I think it's reasonable to do endometrial biopsies, although they are super uncomfortable. If you time them right to a cycle, you can do them in the office. You don't need general anesthesia. There's always a good reason to take a day off work, et cetera. And do I think there may be reasons to do ultrasounds? Yes. And so when we think about prevention, like right now we think of, you know, risk reduction surgery, like it's obviously like a relatively extreme prevention. On the other hand, never getting cancer in itself has some value to it. And, you know, I think there was a time, like when I was a resident back in the day, we did, which was 30 years ago now, we did a lot of hysterectomies people didn't need, right? And then the pendulum swung to over here where we were like, no, you have a BRCA mutation, you do not need a hysterectomy. We are not doing a hysterectomy at the same time. We don't care what you want. You know, like we did that, like over here. And I just hope we can kind of be in this space where we don't assign too much meaning to body parts, right? Are you still a woman if you don't have your uterus? Well, where is that? Where is our gender identity, right? It's in our brain, it's in our heart, it's in our soul. It's not necessarily in our body parts. That saying, again, like I don't believe in taking out body parts unless you have to, and you have to talk it through with a provider. Can we prevent them? I mean, like I said, progesterones are extremely protective. And so, especially if people are not currently trying to get pregnant or want a baby, you know, is it reasonable to be on progesterone for both reasons, the endometrial cancer and the ovarian? Absolutely. Are there good targeted formulations that people can tolerate well? Absolutely. So I think those are worth talking about. Some of the like chemo prophylaxis, like turmeric, non-steroidals like ibuprofen and naproxen. You know, some of the studies we were doing, there was a time we were very hyper-focused on this, and there was huge trials in people who had Lynch and FAP, familial, I'm going to say it wrong, adenomatous polyps, where those Motrin family drugs, these anti-inflammatories, anti-prostaglandins, were incredibly effective. Bummer though, Vioxx, which is what they were using, also caused heart attacks, right? And so, like this whole thing of when you take on a prevention, you certainly can't increase the potential for another disease. I do think that's where when we start thinking about things like turmeric that don't cause heart attacks, like there's a role, and people are studying that currently, and there's the potential it has the same role in endometrial cancer. Different though, turmeric really concentrates in the GI tract different than it does, and so getting it into the bloodstream can be a little more challenging. But there's ways to do it if you're interested, and I'm happy to talk about that. So, this slide I sort of always talk about, right? We've been talking about this kind of best care stuff over here, but obviously all of these other things also play a role both in prevention and in survival of cancer once it's occurred. And so thinking about all that other stuff, right? Exercise, stress management, social support, trying to avoid those things that we know are not great for us, like smoking and drinking too much. Sleeping enough, that's a huge one. And especially in these hormonally mediated cancers, we know melatonin and the circadian rhythm has these direct impacts on things like ovulation and helping us have that normal balance. I mention always the environment. That is a place where we really need to put some thought into, right? There's a lot of things in our environment, the endocrine disrupting chemicals we call them, right? They're in things like pesticides, but also in things like hair relaxants and other things where there clearly may be why we're seeing this increasing chance of getting endometrial cancer among African American women because of the use of products like that. So we'll keep that conversation going. If you'll have questions about that, we'll go to it, but I'm going to kind of get into like I mentioned the old but still relevant approaches to things, and then talk about how we do things new. So primary therapy for endometrial cancer and why it's so curable is because we can do surgery, and often that's the only treatment people need. We have changed how we do these surgeries from the time I started in practice till now. We used to do big old open surgeries, keep people in bed for days, keep people in the hospital for days, and we've of course changed all that. Now we do them with something called robotic surgery, but just to be clear, like I have a picture of the robot. There is no robot in robotic surgery. It's a dumb word. Like what robotic surgery actually is, it's more like a video game, right? You're using a console that allows you to have more fine movements than straight little laparoscopic when you're standing at the bedside. I just think they didn't want to say video game surgery, so then they said robotic surgery. This sounds better, but regardless, there's no semi-sentient, wannabe sentient being between you and the surgeon if you're having robotic surgery. The doctor's doing the thinking, but it allows us to do, we do endometrial cancer surgeries now as an outpatient. Lots faster recovery, less risk of all of the complications, bleeding, infection, blood clots, lymphedema, all of the things that were associated with open surgeries. And now, like similar to breast cancer and endometrial cancer, we use sentinel nodes. So put some dye in the cervix. This is that ICG, the dye we use. This isn't telling us there's cancer in the lymph node. It's just telling us that if cancer was going to go from the uterus, which is right here, and this is the edge of the fallopian tube, if it was going to go to a lymph node, what lymph node does it go to? This is this little lymphatic pathway of that lymph node to the next area. So taking out sentinel lymph nodes means we take out 1 to 2 lymph nodes on each side as opposed to 5 to 7 lymph nodes, which we used to do. Or some people would opt to not take out any lymph nodes and then end up needing radiation that they could have avoided if we had checked out the lymph nodes. So again, sentinel node biopsies let us do things with less complications again, less bleeding, less transfusions, less lymphedema, less risk of nerve damage and blood clots from operating right on those blood vessels, but helping us identify who's at higher risk, and so who might benefit from more therapy. The other thing with sentinel nodes is, when we used to take out lymph nodes, we would just basically the pathologist would look at the lymph node in one space, and now we just do this thing where we look at small. Now, sometimes we get information we don't know what to do. Things like isolated tumor cells comes up in breast cancer too. But we also think we're identifying of those cancers who are the bad actors. that would need and benefit from more treatment. So ovarian preservation is something a lot of people ask and talk about, and certainly it is an option in some early endometrial cancers. It's tricky again, though, all the stuff we talked about Lynch. If you're at risk for getting ovarian cancer, you sure wouldn't leave those ovaries in at the time of a surgery. But it's worth talking through, right? Not all the genes have the same risk. PMS2 might have no risk of ovarian cancer, so maybe it is an option. Again, something to stay on top of and be aware of. Estrogen replacement therapy is the other thing, right? There's a number of studies following women who did get estrogen replacement therapy after endometrial cancer surgery, who had early stage, who had no worse outcomes, right? And so it may be that, again, we kind of vilified estrogen in that pendulum way of being in medicine that we are. So we don't really know in higher stage, but certainly in early stage, likely cured cancers, it's probably an option. And again, it has to be individualized for a whole bunch of other reasons, right? What's somebody's risk of breast cancer? What are their, risk factors for that? Talking it through with them in a meaningful way. So the other thing we've gotten better at, of course, is surgery. This is very baseline, something called early recovery after surgery, ERAS. Right, it's not ERAS, right? Ever since Tara, so people ERAS, I'm like, no, it's no Taylor Swift, nothing, ERAS. And we were there before she said it. Regardless, these basic concepts of, not having people not eat for 2 days, not having people do these things where they clean out their bowel and get rid of all their microbiome, and getting people eating faster after surgery, limiting the use of general anesthesia, versus the, oh, you'll be asleep, honey, don't worry about it, to the, well, maybe we could do this with a block. Maybe there's things we could do that are different. And then getting moving sooner, right? Realizing that healing is different. And of course, that's also introducing smaller incisions where the risk of hernia is less, where the time for it to heal is less, and so getting people moving faster, also knowing that that improves recovery in a whole bunch of ways. Beyond the standard ERAS, are there other ways to think about it? Absolutely, right? We know that all of the tools that we use for stress management in the cancer survival, cancer prevention role also benefit us in the setting of perioperative care. I wrote out my breathing exercise here. We have so much time. All right, we're gonna do a little breathing exercise, maybe warm ourselves up too. So I love this breathing exercise, the 4-7-8 breath. You can YouTube Andy Weil doing it, and he's got his whole Zen way of being where you watch him do it for 4 breaths. But it's nice, and it comes from Ayurveda. So, some people believe this 4, 7, 8 has a bunch of meaning. We know in science that part of breathing and why it helps us is when we breathe out longer than we breathe in, when we pause between, it's like an automatic sign to our nervous system that we are not under attack, we are not being chased by a saber-toothed tiger, right? And we can turn off our fight or flight nervous system, right? We know all the things that turn on our fight or flight nervous system, whether it's the pain of surgery, whether it's worry, whether it's the actual somebody cut into you and so your body does think it's under attack, and in some fashion it was, all of those things, that heightened stress hinders the healing process, right? So anything we can do to talk our body down from that. All right, so we're gonna breathe in now. So in Ayurveda, if you use the yoga position, you put your tongue back here between your teeth. We breathe in through our nose with our mouth closed for 4. We hold for 7. We breathe out through our mouth and we make that whooshing noise when our tongue's up there. So we're doing that whooshing noise. We do that for a count of 8. To breathe out for 8 takes a lot of work. You got to really squeeze those lungs, pull that diaphragm up. And that's the other thing, right? There's all these breathings that overlap. Right, diaphragmatic breathing does the same thing where we really take that diaphragm down, fill up the lungs, bring that diaphragm up, kind of the way babies breathe, you know, as opposed to the rest of us, we spend our time holding our tummy in so we don't look fat, right? Like that is like why people don't take good breaths. Anyway, all right, so I'm gonna count you guys through it. So empty your lungs. Now we're gonna breathe in, 2, 3, 4, hold, 2, 3, 4, 5, 6, 7, breathe out, 2, 3, 4, empty your lungs, 7, 8. We're gonna do it again, in, 2, 3, 4, hold, 2, 3, 4, 5, 6, 7, out, 2, 3, 4, 5, 6, 7, 8. Ideally, you do it the way the yogis recommended it. You do 4 breaths in a row, do it twice a day. The interesting thing is like, it's so clear. Decreased cortisol, decreased all of the stress mediators, all of the like downstream effects of like having that chronic elevation. I think I personally like it because if I'm not counting, then I'm thinking. If I'm thinking, then I'm not breathing, you know. So, but all of these, whether they're breathing exercises, guided imagery, there's a wonderful recording by this woman, Belle Ruth Napper-Steck, called Successful Surgery, that has been shown in studies used before, during, and after surgery, decreases pain medication use, decreases pain in general, decreases anxiety, improves sleep quality. And her recordings are really nice because they have like 3 separate pieces. Like she talks about it, then she does a list of affirmations. And I mean, like, the affirmations are really nice. And, you know, honestly, there was a time like I was like in a whole traffic state of mind that I literally listened to the affirmations when I first got in my car. Because otherwise I was like road rage girl, right? But like just the words, and we know, right, like how powerful language and words are. And, you know, anyway, the Calm app, Headspace is another app. Like all of these things are things you can download on your phone, use in the setting. I'm talking in the setting of perioperative care, but also as we talk about preventing cancer and surviving cancer, you know, benefits in both of those. Perioperatively, nutrition, so important. In order to heal and rebuild tissue, you need plenty of protein. So, right, if we usually think you need, you know, that's, you know, 0.8 grams per kilo per day of protein in normal life, which a lot of people, especially women, don't get. In the healing period, we need to bump that up, possibly to 1 to 1.5 milligram per kilo per day. Regardless, 60 to 80 grams. It's like a decent way of thinking about it. A chicken breast has about 20 grams, a piece of salmon, 20 to 25, a Greek yogurt, 10 to 12 grams. So it's not so hard, it's just that we have to think about it and think about kind of putting protein in every single meal, every single snack. Getting more omega-3 fats, right? So those are the ones that are in walnuts and fish and ground flaxseed, one of my favorite sources of omega-3s, avocados, avocado oil, obviously, olive oil. We think it's one of the main reasons there's benefits of the Mediterranean diet because those omega-3 fats, they are the basic building block of the anti-inflammatory mediators that our body sends around when there's inflammation. Same as omega-6 fats are the basic building block of the inflammation, of prostaglandins, of the things that cause inflammation. And of course, it used to be that these were balanced in our food supply, that beef had both omega-3 fats and omega-6 fats in them. But then we changed our food supply, right? We changed what we fed cows. And that's why grass-fed beef is good, because it has a higher concentration of omega-3 fats because they're eating what they were meant to eat. You know, again, another topic, our food supply. Getting plenty of fruits and vegetables. So fruits and vegetables help us perioperatively because we get the vitamin C, we get the anthracyclines, we get all the things we need to rebuild tissue, to wound heal, to clean things up. But also, it helps reestablish the normal microbiome, right? No matter what, people get antibiotics, people get exposed to all those kinds of things that screw with your microbiome. You're not eating your normal food, reestablishing that microbiome. And the other thing that reestablishes that normal microbiome, plenty of fiber, and then fermented foods, right? The yogurts and the kombuchas and the sauerkraut that's fresh, still in the cloudy fluid, the pickles still in the cloudy fluid, kimchi. Now there's better drinks out there. Kavita is a brand name of a fermented thing that you can get that comes in kind of nice flavors. I'm not a big fermented food drinker, so right, I look for alternatives, and there's some good ones out there. And then drinking plenty of water. In that perioperative period, kind of in life, we need to drink more water. Often we don't drink enough water. And then activity, right? We used to really not let people be active, but there's clear evidence that being active before, in the immediate perioperative period, and after matters. So, and here in this endometrial cancer setting, we're talking about hysterectomies. So prior to surgery, strengthening the pelvic floor and stretching the pelvic floor. So there's a bunch of yoga moves that stretch that pelvic floor. And then Kegels and the whole category of medicines. When we strengthen our core, we automatically strengthen our pelvic floor. So core strengthening as part of a getting ready for hysterectomy process. In that first 4 to 8 weeks after hysterectomy, generally you can't do heavy lifting even with robotic surgery, but you can walk. Maybe you're not up for walking 30 minutes in a row, but you can do 5 minutes 6 times a day, and that may actually be more beneficial in terms of decreasing adhesions, keeping things from stuck together that shouldn't be. After lymph node surgery, it's clear like that going up and down steps, the up and down of our muscles prevents lymphedema and some of the healing around the lymph node removal site. And then once the limitations are lifted, kind of trying to get back to that goal, 30 minutes 5 times a week, over and over in multiple cancers, in multiple different studies, we've seen that 30 minutes of moderate to vigorous activity 5 times a week, 150 minutes a week, has been linked to decreasing chances of cancer recurrence. In breast cancer, it's 25 to 30%. In other cancers, in colon cancer, the same. In prostate cancer, about the same. It kind of makes sense. Exercise also does that job of turning off our fight or flight nervous system, turning off all those inflammatory mediators, turning on the healing part of our system. One of the things our body does when it's in that parasympathetic healing time is it's less likely to make genetic mistakes, because all of those genes that work to repair genetic mistakes have opportunity to work. We think that's part of the cancer prevention process that we get from physical activity. People often benefit from things like pelvic floor rehab after hysterectomy. So keeping this open conversation about what symptoms you're having, what's going on, if you're having bladder symptoms, if people are having pelvic pain, what you can benefit from. And there's this woman, Leslie Howard. She does a bunch of YouTubes, really nice pelvic floor stretching and other stuff. And is a nice resource. Other things around surgery, I do have people do a little bit of zinc and vitamin C because it seems to really help healing. And somehow we also know, like I mentioned, it does seem like some of our food supply doesn't have the same nutrient denseness that it should. Lots of people have sore throats, and these throat coat teas and licorice root teas. This Traditional Medicinals is a great company, and those actually the licorice root has been studied and markedly decreased sore throats and improved energy perioperatively. Getting enough sleep around surgery can be really challenging because you're in pain, you're uncomfortable. Narcotics mess with our circadian rhythm and our sleep cycle. So thinking about melatonin, which a number of studies using perioperative melatonin showed improved outcomes. Melatonin's also part of that whole stress hormones, female hormones, melatonin, all are structurally similar, and so they have really deep interconnections. And so there's potentially a role for melatonin. Again, when it comes to supplements that are actually in that thing, I always say talk to a provider, herbalist, an integrative oncologist, your primary care docs. For people who have lymph nodes, even sentinel lymph nodes, I generally have people wear athletic compression socks. I think everybody in the universe should own a six-pack of compression socks. You go on a flight, you're on a car ride that's more than 3 hours, think about wearing compression socks. A little plug for blood clot prevention there. Other treatments for endometrial cancer, radiation is a big part of it, and we've gotten a lot better now that we're doing sentinel nodes of choosing who gets very focused radiation, right? Radiation just to the top of the vagina versus whole pelvic radiation, where there's potential for metastasis or spread in the pelvis or to lymph nodes. We try to avoid whole pelvic radiation when we can because there's longer and more short and long-term side effects. And even after treatment, thinking a lot harder about pelvic floor stretching and rehab, thinking about using vaginal dilators to avoid the narrowing that can happen at the top of the vagina. And then, that just top of the vagina radiation that has substantially less side effects, maybe a little scarring at the top of the vagina, but when someone's had their sentinel lymph nodes checked and proven negative, lots of times if they need radiation, they only need that limited amount of radiation. And then, of course, there's that setting of when people have more advanced disease, right? Thinking about when we're worrying about cancer that can be somewhere else in their body, thinking about chemotherapy, and now specifically, especially in these mismatch repair genes, thinking about these checkpoint inhibitors. Those are the pembrolizumab, or Keytruda is the other name, but showing a lot of benefit in decreasing and are making us better at curing stage 3 and stage 4 endometrial cancers. We also do use hormonal therapies in the setting of endometrial cancer, things like progesterone actually, but also sometimes aromatase inhibitors if we're worried about long-term risks. And if an endometrial cancer comes back, we can sort of take on that same range of things, right? Sometimes surgery, sometimes radiation, sometimes chemo, sometimes these more targeted therapies and hormonal therapies. This is a list of the chemo options, and then this is a list of some of the targeted therapies where, again, having a mismatch repair gene means all of these treatments may be things that are effective. But many, even Lynch-related tumors, will have other genetic changes that allow us to use other targeted therapies, right? Because it was a two-hit process that led to that cancer. And then hormones, we use hormones again in the setting of cancer recurrence. As I mentioned early on, and as I was talking about the NCCN, right, endometrial cancer in general is very, very curable, with cure being related to stage. And again, endometrial cancer with the abnormal bleeding, change in bleeding patterns, postmenopausal bleeding, helps us to pick up these cancers early. And then, like many cancers, right, prognosis is all about stage and some of these other factors we talked about. This last kind of concept of why we're seeing higher rates of endometrial cancer in African American women, maybe it's about these endocrine receptors, maybe it's about, there seems that there is some element of African American women not always being offered the same treatments that people of the white race are being offered, or Asians actually have better outcomes. Again, though, how genetics plays into this, we know that BRCA genes or Lynch genes don't travel with skin color genes, right? We know that's not true. But are there other factors that come into play, whether they're about diabetes or hypertension or other things? Absolutely. But it's clear that racism is part of it. So, right, just summarizing hereditary endometrial cancer, we've got better options for early detection and prevention if we think about progesterone IUDs. We have immunotherapies now based on genetics that are giving us a better chance of curing advanced cancers. And, I always mention my gratitude to Forrest for actually giving space for people who have mutations to gather information, to advocate for themselves, to teach people who are doing this kind of work how to take care of them better. it's all really good work, and 25 years is a long time, but it's also kind of a short time if you think about how much has been achieved in that time. So I think we have plenty of time for questions. We're a pretty small group here, and I don't know what brought you all to this conversation, but are there any questions about this or Lynch or anything a gynecologic oncologist with a background in integrative medicine might know?
One thing this was awesome, thank you so much. One thing I was just going to ask is, when you asked the tumor, because I know back a long time ago they were doing studies in heme, and you had said it's hard to get into the bloodstream, but then they said there was an difficulty with potency, and you have to take so much of it. So what's the...
Right. Yeah, let's talk about it. So turmeric is the plant, the root that you can pick up at a grocery store. Curcumin is the anti-prostaglandin in it. That's actually the thing that makes it yellow. And in order to get anti-inflammatory doses in your bloodstream, it is one of those things that food amounts are not enough, right? So now we do have supplements, and there's a bunch of things you can do to take. So if you want turmeric in your GI tract because you have Lynch and you're trying to prevent colon cancer or decrease polyps, then eating it for sure, and then taking it as capsules without any of these special things. But now you can get turmeric that is combined with pepper, which again, right, we learn so much from how we actually do stuff. When you cook with turmeric, most foods have pepper in them also. The other thing we know is fat. If there's fat in that meal, it'll help absorb it. What's a traditional way to get turmeric? With milk, right? With whole milk, and there was fat in it. So really interesting, right? That we naturally, in the indigenous, so to speak, way we used it, was a way that would have improved absorption into the bloodstream. But turmeric is also now being made with these chemical packages that protect it through the GI tract, so help us absorb it better. So there's piperine formulas, there's phytosome formulas. If you look up phytosome formulas, Doctor's Best has one, Thorne has one, there's some more expensive companies, but all of those are ones that are designed to try to keep them from being broken down in the GI tract and give them a better chance of being absorbed. But with food, with pepper, with a fat-containing meal, you're going to improve your absorption. And the truth is you're going to improve the absorption of everything. You should take multivitamins with a meal, because a lot of the fat-soluble vitamins, vitamin D being a huge one, do not absorb well without fat in the meal. And so you won't be absorbing it. And that's a problem I see a lot. People are I've been taking 2,000, international units for years. Why is my, D low? Because they're taking it with all their other pills first thing in the morning, and it's just not absorbing. And, it is too bad, the whole, a couple things that happened, there was the whole Vioxx mess where that company lied and didn't tell people about the heart attack. So when it finally came out, again, it was nobody wanted to touch that with a 10-foot pole. And then there was a scientist who was doing turmeric studies who exaggerated the benefits. And then everybody thought there was no value, and so it sort of hasn't been studied in a while, but hopefully we'll pick it back up, because it is really clear that it has that anti-inflammatory properties. And I don't want to make it too small. Putting it in your food is valuable, right? The tricky thing is when we look at those cultures where we really see the decreased cancer rates, they have turmeric in every single meal, right? And I don't know, people put turmeric on their popcorn. I think that doesn't taste good to me. But whatever works for you. But it's tricky, right? Unless you have a ton of butter on your popcorn, maybe you're not absorbing it. On the other hand, maybe it's staying in your GI tract and it's giving you benefits there.
I think also important to note that some of those supplements, the side effects turmeric's known in the blood also.
So turmeric, it hasn't. You're told to stop everything, and I absolutely 100% understand anesthesiologists, and I understand that process. I mean, I try to keep people on vitamin C and zinc, and they'll be told to stop that, and it's clear that those don't do anything. The trouble is we have limited studies. So turmeric has this potential because it works in that prostaglandin way, and because we know aspirin and Motrin that work in that prostaglandin way. But what we think is that turmeric is, so aspirin is like, it permanently turns off certain prostaglandins. That's why it's so effective at preventing blood clot, because it really has a clear cut. Motrin does it reversibly. As long as it's around in your bloodstream, it'll continue, but once it's out of your bloodstream, it stops. So that's why 2 or 3 days. Some data suggests that turmeric does it at worst like Motrin, but it's unclear. But that's why we stop it. Same as I even meant, or maybe I didn't mention in this talk, but like fish oil. I do tell people to stop fish oil around surgery because there's this theoretical thing, but nobody's ever actually seen it. But again, when you can get turmeric in your food, and when you can get fish oil or omega-3 fats in your diet, why not do it in a way that we know your body can make choices about what to do with it?
Big industry of all the supplements, it's not regulated, so you really don't truly know.
Yeah, you should have come to my earlier talk. But but no, it's a real problem. And it's a real problem in multiple ways, right? So there's the one thing in the United States, the FDA considers supplements food. And the truth is, like, you know, box of cereal, you can put whatever the heck you want in it, right? Even you can write toasted oat on the outside. It doesn't have to have a toasted oat in it. So the same is true of supplements, and finally we're starting to change that. Now in Europe, it's completely different. Herbs and supplements are completely controlled by their FDA, and so, you know, they're always like a source to go back to, and we are getting better in this country about thinking about it. There are like good companies out there. If you have access, you'll have access to my slides that I talked earlier specifically about integrative medicine, and in there I listed a bunch of things. There's a company called Consumer Lab. If you look up Consumer Lab, like, they're really good. They do nice reviews. They only get their money from people like us. Being a member, I think, is like $20 or $30 a year. And, you know, they even review like good companies, bad companies, all of them, right? The best way to get cinnamon, it's a Walgreens brand, as it turns out. One of my favorite companies, Gaia, actually doesn't do turmeric that well because they like to put, and I love Gaia for rhodiola, I love it for a whole bunch of herbs, I love it for maca, this, you know, herb that may help with decreased libido, but because they like to turn things into a tincture, which is like a Chinese medicine kind of concept that you take herbs, you make them into a tincture, they absorb better. But that doesn't work great for turmeric, because it needs fat, right? So a tincture and alcohol doesn't make sense. So Consumer Labs is a good company. You know, the sort of, I struggle a little bit with these companies that come up with these proprietary formulas and that can cost $1 million, and you don't need $1 million vitamin, right? On the other hand, like, one-a-day vitamins are bad for us. They have synthetic vitamin A in them that increases the risk of getting cancer. But it lives longer on the shelf, and so it stays there. One-a-day, Centrum, anything that has retinol in it is not good for us. So, like, but there's a space in between, right? The $1 million vitamin versus the, 50 cent versus the $10, and kind of where it makes sense. But like other good companies, Solaray is a good company, Doctor's Best is a good company, Now is a good company, NOW. For melatonin and 5-HTP, the company Natrol, N-A-T-R-O-L, like, they make time release formulas, which are probably kind of the closest to like how our body actually would make it if we had enough evening light that led us to like a natural buildup of our melatonin. So there are good companies out there, but it's a real problem. And honestly, like, I'm always talking to the group here at Force about, like, can we come up with a list of integrative providers that can help guide people? And it's tricky. Like, there is a board certification now that's kind of helping, but like, people are trained in different ways and have different sets of beliefs. There are some people who believe really strongly that hormones are, I think they overvalue hormones and over-prescribe. And, You know, there's a lot of skin transdermal use of hormones that I think is tricky. I do think patches are great, but that's different than creams where like how much you absorb is really different. So I don't know, I think it's hard. I do think like going to academic centers, you know, the same way you get second opinions for cancers, like academical centers will have people. So a lot of them now have integrative medicine programs that are really good and at least can provide guidance. And then once you have a connect, you can do telehealth visits. A lot of places will do telehealth visits. Yeah, somewhere we need better, really better. Other thoughts, other questions? Yeah.
First one is, for the group too, is you mentioned olive oil, but I've read that, I cook all the time, I cook tons of olive oil. I've heard that I denature it though by cooking it, so it's really
Right.
that's
So
really
at that high heat, use avocado oil.
avocado. Okay.
Right. It'll withstand the heat.
Okay, and my second question is more personalized, but for the group. So I have PCOS, had it for years, been on metformin for years, not regulated my sickness, and actually I got pregnant.
Yay.
Which was crazy. But anyway, long story short, my OBGYN told me that I could go off of metformin because I don't have an increased risk for endometrial cancer. But in your slide, you said PCOS is an increased risk.
So we don't totally understand it, right? So just like being overweight, PCOS is like multifactorial. There's a little bit more testosterone around, there's anovulation. So her thought process might be that like once we've gotten you back to regular ovulations and regular cycles, so much so that you could conceive, have we eliminated the increased risk of endometrial cancer? Possibly. Possibly. It's tricky though because is why do people get PCOS? Is there something that the ovaries are doing different hormonally? Is there something metabolically that makes us different? That might be part of the process. So we don't know the answer to that. And
Well, I'm going to stay on it.
well, and that's the other piece I think that's really tricky is because PCOS is such a broad thing that there were a couple studies that implied that metformin shouldn't be used for PCOS without a diagnosis of diabetes. And again, like I think it's baby with the bathwater. Like one study showed something, and maybe it was defining things too strictly. Maybe we don't totally understand it, but there's this clear role for metformin. Even in endometrial cancer, it's been looked at. In endometrial cancer treatment, it's been looked at. The findings aren't clear. Probably it needs to be connected to something like progesterone to really make it effective. But I mean, the problem with, taking this is why I put quotations around the NCCN, right? That's for like when you're talking to the whole population. But it's worth like sitting with your OBGYN and kind of talking through, was it something about you or something about changes in the recommendations that led her to say that?
So I had a question about the immunotherapy.
The checkpoint inhibitors, yep.
So someone I know is on Jemperli.
Oh, will you tell me what it is? Distarlimab, got it. Yes, that's a good one.
So I think she just finished chemo. Was that, I think it was in conjunction with traditional
Yep.
chemo,
Yep.
and then she's going to continue on that?
Yep, for maintenance. And it's kind of amazing, right? The benefits, like those studies just last year got approved.
It just came out like in 2023.
23, right. I
Yeah.
think in March is when the FDA approved it. But what's really interesting is, so we see the most benefits in people who have those genetic changes, whether they're inherited or in the tumor itself. But even the tumors that don't seem to have improved responses. And that's what that study showed. And so I think it's worth it. It's tricky because we kind of characterize chemo as poison and everything else as not. And that's not quite true. Just like Keytruda, Distarlimab, it has a bunch of side effects. And so kind of talking them through. And of course, 6 months of treatment's a whole different ballgame than 2 years of maintenance therapy. And so she'll have to see how it goes, see how she does. But there is clear evidence that one of the things we used to do wrong about cancers is once we couldn't see it, we stopped treating it. And breast cancer is the one that really taught us that maintenance therapy, something you do for multiple years afterwards, is actually catching those. Were they dormant during the process? Did they start growing later? We don't know why, but why these cancer cells come back. So maintenance therapy So like, I think like we're understanding better like that we probably do need to treat longer. We haven't quite scienced out how long do we treat, and so we use these generic like 2 years for everybody, same as PARP inhibitors and ovarian cancer. Like, although PARP inhibitors actually I think have more side effects than some of these immune checkpoint inhibitors. And I don't know if she's in her maintenance phase or her main phase. Like, it's a lot harder in the main phase.
Right.
They're a lot more tolerable in that maintenance therapy time.
Yeah, she's just gonna start the meeting.
Yeah, good for her. It's nice that we have more tools.
Well, my daughter, I have Lynch, and my daughter has it, and what age are you thinking that women should start having the endometrial biopsies?
I usually sit with people individually, like look at them, look at their history of, pregnancy and oral contraceptive use and IUD and all that other stuff. We think depending somewhere between 35 and 40 is a reasonable time to start thinking about it. But again, I would look at that whole part, and her OBGYN can do it. And if her OBGYN is struggling with it, lots of GYN oncologists will do a consultation, even though she doesn't need them long term. Maybe in the short term, at least they can do the thought process with her of kind of when is there a benefit to that? Is there a benefit to it? Kind of what makes sense? Is there a benefit to getting a progesterone IUD? Potentially. All right. Well, thank you everybody for joining us, talking about this less common thing. Really appreciate it.
About the evaluation and the conference after the session.
Thank you so much.
Awesome. You're welcome. You're welcome.